exchange one. I'll double check because it's there. Hi everybody, sorry if we can just get ready to start with this session, please. So my name is Rob Davis. I'm one of your incoming council members. So hello, nice to meet you all, and also welcome to those joining us online. So I'm really pleased to be able to share this session where we've got a couple of abstracts being presented by some of our colleagues. So what we're going to do is we're going to run it as the present abstracts can be presented back to back, and then we're going to have a kind of combined question and answer session at the end. So in order, we'd like to invite from Matthew Kelher from the University of Winchester to come up. He'll then be followed by Molly Stannard of Health Sciences University, and then Pauline May from East Lancashire Hospitals NHS Trust. So Matthew, if you'd like to come up, please. Thank you.
Okay, while the slides come up, good morning. I just want to say thank you for joining me today and giving me the opportunity to talk to you and share this research. So ADHD is a neurodevelopmental disorder which affects roughly 3.15% of adults. And though presentation can vary significantly, ADHD is characterized by hyperactivity, impulsivity, and/or inattention. In adults, this commonly manifests as difficulties in prioritization, organization, focusing, and forgetfulness. ADHD has been shown to have wide-reaching effects on social, functional, and health outcomes across the lifespan, including increased incidence of a vast array of health conditions, not limited to chronic pain, fibromyalgia, arthritis, increased incidence of accidents and injuries, chronic fatigue syndrome, and numerous comorbidities compared to the non-ADHD counterparts. Symptoms of ADHD have been observed to present a significant barrier to ADHD adults' physical activity and treatment adherence, which are core parts of musculoskeletal and other physiotherapy treatments, and could therefore affect physiotherapy outcomes. Critically, previous research has focused on direct treatment of the psychiatric perspective of ADHD and describing the aforementioned poorer outcomes. And little is understood about how ADHD impacts healthcare experiences, nor the practical implications for supporting and improving outcomes in this group. The combination of poor health outcomes and lack of literature of professional guidelines raise the question of whether better understanding of ADHD adults' experiences could help to inform changes to physiotherapy practice and ultimately start a journey towards improving these outcomes. And as such, the purpose of this study was to explore the physiotherapy experience of ADHD adults and collect views of ADHD, physiotherapy's ADHD inclusivity and potential areas for improvement. This study followed a phenomenological sequential mixed methods design due to its potential to capture a richer narrative within a previously unexplored area. An online questionnaire featuring 5-point Likert scales was devised to cover a breadth of the physiotherapy experience, and free text boxes were also provided at the end of each section to allow participants to record greater detail relating to these areas. The questionnaire was disseminated via ADHD-specific communities on subreddits and social media platforms Reddit and Facebook. An initial thematic analysis was completed of these free text boxes to identify areas which warranted further exploration. These informed the creation of an interview guide, particularly targeting the general experience of ADHD as a factor in their experience, perceptions of inclusivity, and what they believed a physiotherapist should know about ADHD. Semi-structured interview participants were recruited via an opt-in form, which was presented at the end of the online questionnaire, and they lasted around 45 minutes each. So quantitative data from the questionnaire was processed using SPSS, with Spearman's Row being used to assess for correlations between non-parametric questionnaire domains, and Mann-Whitney tests were used to assess differences in experience for those whose physiotherapist was and wasn't aware of their diagnosis. Questionnaire free text and interview transcripts were combined and analysed through reflexive thematic analysis. So the important part, the results. So 50 participants met the inclusion criteria for the questionnaire, which was looking for adults with a formal diagnosis of ADHD who have received outpatient physiotherapy within the last 12 months. Though most participants reported overall positive experiences, 60% of participants somewhat or strongly disagreed that physiotherapists understood how ADHD may impact their treatment. What is likely the strongest point from this study is that 75% of participants found adhering to exercise to be somewhat or very difficult, with 94% of participants considering the ADHD to have been a factor in this difficulty. There was a significant and moderate positive relationship between overall experience and perceived knowledgeable physiotherapists. Reflexive thematic analysis of the combined free text boxes and interview transcripts revealed 4 main themes. The first, a feeling of being misunderstood and unsupported by physiotherapists, which stem from the lack of opportunity to discuss their ADHD, a lack of knowledge from the physiotherapist, which include a frustration of feeling the need to educate physiotherapists on the basics of ADHD, or a lack of meaningful action if the ADHD was discussed. The impacts of ADHD were most keenly seen in exercise adherence and difficulty managing this aspect of physiotherapy, though further aspects were highlighted during appointments, with the setting lending itself to distraction, with one patient mentioning the thin curtains in the outpatient setting and struggling to tune out others' consultations. The most concerning theme was disengagement of some participants from their physiotherapy, with their difficulty participating causing a sense of pointlessness and hopelessness, and ultimately leading to some to self-discharging or not attending appointments. The final theme of how physiotherapy could be more inclusive placed importance on developing an understanding of what ADHD is and how it could affect those attending your setting, and generating a conversation around what difficulties they may face and what support they may benefit from. Though some participants mentioned the use of apps, reminders, and understanding the nature of ADHD when it comes to administrative burden of accessing healthcare. So the takeaway points from this are ADHD adults consider ADHD to be a substantial factor in their physiotherapy experience. There appears to be an unmet need within this patient group, and considering the poor outcomes and associated health costs presents an exciting area for future research if we can improve outcomes and reduce costs. There is a perception by ADHD adults that physiotherapists do not have sufficient knowledge of ADHD, though this is not unique to our health profession. As physiotherapists, we have a professional responsibility, and I would urge, as a fellow physiotherapist, to learn more about ADHD and consider that everyone in this room will likely have many patients across their career who've had ADHD, whether you're aware of the diagnosis or not. And I leave you to ponder how many times you've seen written, did not attend discharge physiotherapy, or not adhering to treatment, discharge therapy, and whether there could be something else to it. And one final quote from this study. This time they've listened to me and worked with me to make treatment accessible. And guess what? I'm compliant and rapidly improving. This research was completed earlier this year as part of my dissertation at the University of Winchester, with the help of the Physiotherapy Research Society. I've been fortunate enough to present as a poster as well. And essentially, thank you for listening. And please come find me anytime today if you want to chat about this further. Thank you.
Wait for the slides to come up. So, hello, I'm Molly. I'm an MSc Physiotherapy student at Health Sciences University, graduating in 2025 in January. So this research was conducted as part of my undergraduate research. And first of all, I just want to say how much of an honour it is to be stood here presenting today during Baby Loss Awareness Week. So, firstly, this is an emotive and emotional topic, and so I've included some QR codes for support on screen. Note there is no affiliation with these charities and the research conducted. So physiotherapists, like other healthcare professionals, are likely to come into contact with women who have experienced miscarriage, and therefore understanding their experiences is key to supporting these patients with patient-centred care. So, the NHS state that miscarriage is the loss of a child before 23 weeks of gestation, and 1 in 8 pregnancies will end in miscarriage. This can be argued to be slightly different depending on what statistics you look at. The Department for Health and Social Care state that 250,000 pregnancies in the UK alone will end in miscarriage every year. And we know that this emotional turmoil can lead to depression and anxiety. Previous studies, however, have not explored these women's experiences fully, possibly due to partner biases, environments used, methods, participant recruitment, or researcher bias. Therefore, the aim of this research was to explore women's experiences of miscarriage and develop better understanding of their needs. So in terms of our methodology, we recruited 7 participants with an average age at last miscarriage of 30 years. Half of those participants had had multiple miscarriages. Snowball sampling was used for recruitment, as well as the use of social media, and participants partook in a one-to-one interview, which was semi-structured and online. Interpretive phenomenological analysis, or IPA, with an ontological approach of critical realism, was used to interpret the results. So, our emerging themes. So, emerging themes showed that women's experiences were mixed, complex, and emotive, and women reported both positive and negative responses to healthcare services and the charity sector. Our core themes being displayed on screen, being language, environment, and education. So let's start with language. First of all, many of the women commented upon well-meaning language that they realised was there to attempt to support them, but didn't quite hit home in the right way. They commented upon medical terminology, the use of the word sac or tissue instead of baby. And one woman was very passionate about the use of the words at least, talking about at least. I don't want to know at least. As far as I'm concerned, my baby died. In terms of the environment, we understood that physical environment can impact emotional well-being, with women talking about having to walk past other pregnant women after finding out they'd just lost their baby, or feeling cut off in tiny rooms. And then when it came to education, this was highlighted by the use of the words didn't know by nearly every participant we interviewed. This commented upon school-based education, education and understanding during miscarriage, as well as possible education and awareness of health professionals. So therefore, our results suggest that first contact services and healthcare professionals have a role in providing information on miscarriage, as well as possible needs for extended training and/or education around support, impact, and the psychological effects. The clinical implications of this coming under these three themes being the awareness of the language we are using, referring to the woman as the mother, using supportive signposting, using the term baby instead of fetus or sac, considering during building and development the pathways which these women are taking directly through our hospitals or services, considering in family planning, sex education curriculums and within antenatal settings an increase in education, and an increased awareness of charity sector provision. This research was conducted before the release of the 2023 Pregnancy Loss Review, however, actually supports many of the issues raised within this. But we know that more research is needed. Therefore, I am currently conducting the next stage of this research, which is looking at the healthcare professionals' experience of supporting these women. So if you want to take anything home from what I've said today in my short 5 minutes, it's talk about it, because nobody does. So finally, and to finish, I would like to say thank you to the women for their bravery and strength in telling their stories so that we can hopefully change the pathways for our future generations. Thank you.
As physios, in order to provide the most effective care for our patients, we need to understand the patient's perspective. My name is Pauline May. I work at East Lancs Hospitals, and I'm also undertaking an NIH or pre-doctoral fellowship. And I'm going to spend the next 5 minutes or so talking about the qualitative study that made up the majority of my fellowship. So I'm talking about a shoulder fracture. For clarity, what I mean is a proximal humerus fracture, but to keep it simple, I usually just say shoulder fracture. So this type of fracture, it's very common. The latest numbers that I've had is 24,000 in England and Wales in 1 year. This is old data from 20 years ago, but the incidence is said to be increasing. And there's a large cost burden to the NHS, but also a large cost burden to the patients themselves. This injury has generally got quite a long recovery process, and it can often be an incomplete recovery. So I wanted to explore the experiences of patients with these injuries in order to improve the care that we provide for them. So I wanted to explore their experiences, what are their information needs, and what are their views on recovery over time. So what I did was a longitudinal, qualitative, semi-structured telephone interview study with participants who have sustained proximal humerus fracture. Or in simple terms, I spoke to people on the phone who had had a fracture to a bone in their shoulder at 2 time points along their recovery to see what their experience is like. So the time points that I used was, the first time point was about 2 months after their injury, and then I interviewed them again about 6 months after their injury. I got a diverse group of patients, aging, the age range from 44 up to 80 years. I got 11 female and 3 male, so 14 altogether. Most were white British, but I did have 1 Indian and 1 Pakistani. And the index of multiple deprivation based on their postcode ranged from 1 to 9. After each interview, they were transcribed verbatim, and I used reflexive thematic analysis to analyze the data. And I've just written it up and submitted for publication. So coming on to the themes, the first theme, dependence. As a physio, I expected people to tell me that they've got loss of range of movement, loss of function, loss of independence. But it went further than that. It went more to a change in role or a loss of identity. Like for this lady saying that, that she needed to get her mother to help her. It was like she was going back to a child again. Another participant said that her children needed to take care of her. So it's that loss of identity. In the initial interviews, it was more to do with self-care and loss of independence and self-care. But by the second interview, it was more to do with work and hobbies. Vulnerability encompasses aging, fear of falling, but even more than that, an isolation. Like this lady was so fearful that she didn't want to go out. She felt that she was bound to home. And people, even after 6 months, they were still avoiding certain activities, certain routes that they would go for on walks. Confidence was starting to return for some, but not for everybody. Then if we go on to the theme of information and communication, there was a sense of abandonment, a sense of feeling in limbo. That is the term that one person used. She felt in limbo. She was told what the injury was, but then it was only afterwards thought, well, what do you mean by that? What do I do? It was only after she went home that she realized she wanted more information. And then she had to wait for quite a while, 2 to 3 weeks, before she had another appointment to get the answers to her questions. But on the other hand, I don't have the quote up there, but there was another patient who commented that actually at the start she wouldn't have been able to take in any more information because of the amount of pain that she was in. The information needs of patients varied with time, depending on their priorities with their recovery. And recovery meant different things to different people. So for some, it was to get full movement, to be pain-free, to get back to doing the activities that they wanted to be able to do. But again, for others, it was having my identity return, like this quote here. It was, again, that loss of identity returning that they wanted. So this is the first study to explore the patient perspective along the time frame of recovery after this injury. And recovery goes beyond just the range of movement. It's a lot deeper than that. The feelings of vulnerability and loss of identity are very strong within this group. Effective communication on our part is important so that we can guide those patients in the most effective way through their recovery journey. And as clinicians, guiding patients away from feeling in limbo to giving them the control that they need so that they can be as effectively get their recovery back, get their identity back, and recover fully from this injury. So that's what I would urge you all to think about. Think deeper. think about how these injuries affect people. Not just this injury, it may be applicable to all physiotherapy patients that we see. Sometimes it's about digging a bit deeper as to what is the real problem that these patients have. Thank you.
Great, thank you very much. So I'd like to open up the floor to questions. Oh, where's the mic? Marvellous. Bear with. If you can just state who the question's from, we'll probably get it from the theme, but just for those benefiting online, and we'll see if anything comes online in a bit.
My question's to Matthew. I work with quite a few patients in a pain service with ADHD. So what you're saying is very common and very true, and I think sometimes we're not very good at acknowledging that. Did the patients give you any indication about what exactly it is that is helpful to them? And I know that is kind of patient specific, but are there any quick wins that we can think about?
So I suppose the biggest thing I took away from it was gaining a better understanding of ADHD and what it means for the person, what it potentially could mean. So I think I mentioned that there was this frustration from some patients. They were essentially having to educate us on what it means to be ADHD in physiotherapy. So we're the experts as physiotherapists in our area. If someone's attending physiotherapy or a pain service, something for the first time, they don't know what we have to offer and sort of what's going on. So previous coping mechanisms or strategies may not be relevant to our area. And so I think getting a better understanding of what it means, absolutely. When it comes to things like administration, there is a lot of administrative load potentially placed on people, which can be very difficult, particularly if you're talking about forgetfulness and such. If someone gets a letter through, that may be forgotten about. And so I think if you have identified a patient has ADHD, doing your best to support them with reminders, with giving them a call potentially the day before, or if there is an issue of forgetfulness, I think we maybe need to be a little bit more forgiving potentially of some patients when it comes to that. Some of the participants did talk about apps and reminders particularly, but unfortunately I'd love to be able to give a really prescriptive idea of what we need to do to support our patients, but for me that is sort of the next step in the research, is trying to get to a point where we can say, here's a list of things that might help. But I suppose for starting points, it's learning about ADHD and having an open, honest conversation about what does your ADHD mean to you? Like what are the things that your ADHD causes you to struggle with, and how can I help you? Yeah.
That's great. If you ever need any patients to help with research, we have loads.
Great, thank you. Any other questions at all? Oh, just over there.
Just a question for you, Molly. Just in relation to when you were doing your research about obviously miscarriages, whether you found any relation into how early women had their miscarriage was and how they were interpreted to necessarily be feeling?
Yeah, so within the participants we researched, 6 of them had had miscarriages before, I think it was 12 weeks, and 1 had had a much later miscarriage. And before that 12 weeks, it really varied. I think the biggest thing we learned was actually from many of the women commented from the point at which they got a positive pregnancy test, they viewed themselves as a mother. And actually the emotional turmoil and the effect that then the miscarriage had, although for the woman who had gone much longer term, and that experience was then really difficult because they had to birth their child in a different form, actually the emotional part of that is the same for every woman. It doesn't matter whether it's a week, 2 weeks, 4 weeks, 12 weeks. It made no difference to the women, and it's very much about the experience of the miscarriage itself and the trauma that the miscarriage can be, where they presented, whether they needed additional treatment, whether they felt that what they were offered initially was substandard, or whether they felt that they were being supported. So I guess the short answer is no.
Thank you. Oh, over there. Sorry, just while we're getting the microphone over, I just want to kind of come think about a point Pauline made, and I think it kind of correlates across all the talks about communication. And I think so much. So my practice, I specialise in Parkinson's, and I see people when they're newly diagnosed, and they'll come to see us after they've seen the consultant, and the consultant has said to them, "You've got Parkinson's," and they've carried on talking, and they've not taken a word of that in. And it's like when patients have got injuries and they're engaging, they're experiencing loss, their brain they just haven't got that capacity to process it all. And it's about thinking, okay, so I'm in this situation. How am I going to give this information so that the patient's if they got questions, 3 weeks for a follow-up appointment, it's a long time. It's a long time anyway, isn't it? Have we got leaflets? Do we do a letter? Is there a phone line? That kind of stuff. It's about thinking about what kind of safety netting we've got. And you've probably got lots of stuff out there already. But I think it's just really important to make sure, we think, because I think we all think we're really great at communicating, and lots of us are, but we can't, kind of people don't always take it in. And it's about how we can address that. And sometimes it is just giving that person that permission, say that, is that you understood? Do we need to take 5 minutes? So communication is really underpowered, and I think that's definitely come across all the themes. So that's great. Thank you. So yes.
Perfect lead up to my question. So I'm a consultant physio in fracture clinic at Wigan, and I see the patients as the first port of call. See a lot of proximal humerus fractures. The ones I know aren't going to have operations, which obviously are quite a large number nowadays. So I've revamped the patient education, and we've got a helpline, and I try and preload a lot of the expectations and pain management and that kind of thing. It's still in process, the leaflet. So my question is there anything that came out of your research that was thematic that that I may have missed in the leaflet that you think would be really essential information for that patient to get at their first appointment?
I'm still working on what comes out of this research. I have had meetings with my PPI group and contacted the consultants as well to try and find something that's going to work. The difficulty is that the advice may be different, even though it's the same injury. It's the extent of that injury at the start. The advice will be different for different patients. So it's trying to figure out how is the best way to put the appropriate information there and have it available to patients. And it is difficult because some people want absolutely all the information and some just want the very basics, and they won't be able to take in, or they won't bother to read the information if it's too much. But what I also have realized that I need to do is go even before fracture clinic, go to A&E, because for a lot of patients, it was the wait between A&E and fracture clinic. That was the in limbo area that they were told, right, you've got a fracture, give you a sling, off you go, you'll get an appointment. And it was that time that they didn't know what they needed to do. And that is also the time when they're in the most pain and the shock of the injury. So it's going before fracture clinic that I feel that we really need to go.
We do also have a virtual fracture clinic. So they're usually reviewed within 48 hours, and then they get a call. So we give that advice on the phone.
Yeah.
Just for the benefit of our online audience, there was just getting a comment there about you offer a virtual fracture clinic that offers it review in 48 hours. Sorry. Oh, microphone's coming.
Sorry. We'd give verbal advice on the telephone prior to the appointment, so that they had some sling management, that kind of thing.
Implementing within our trust, but it did vary from some people had their fracture clinic appointment within 2 days, and then others for various reasons were a lot longer than that. Yeah.
Thank you. Yeah.
Hi, mine's for Matthew. I'm Jamie. I really like your research, and I can tell you've done it in quite like an outpatient, like typical setting. I was wondering, kind of given a lot of the stresses that can come in the acute environment, obviously it can be a lot of sensory overload, and we're really aware of that in patient groups like traumatic brain injury, and we really control the environment, or in dementia. I wondered if you had any plans in the future and wanting to look at that and the experiences of patients with ADHD from an inpatient point of view, and how good we are at physios of considering those needs.
Absolutely. I'd love to look at that patient group. I think for me, when I was doing the initial research, the outpatient group made it, I suppose, a simpler way to recruit. So the way that people often access physiotherapy or are aware of physiotherapy, and that outpatient sort of, it seemed to capture sort of the largest group within that. But absolutely, how ADHD may affect people in the hospital environment could be huge. I mean, when it comes to distractibility, you know, if you're in a ward, you're in pain, you're not feeling very well, you've got someone next to you who's making a lot of noise, you might really struggle to follow what the doctors are saying or to retain that information as well. So working memory is a particularly big thing in ADHD as well. So absolutely, I think it would be great to do more in that area and just sort of work out what it is we can do to help improve those experiences, whether that's a side room might be a bit better, or maybe, you know, we're talking to patients about important things, we don't do it in a room with 12 other people with lots of noise going on in a way that doesn't help the patient make the best decision. I suppose just to quickly grab onto the end of the question, just to also add a little bit to the question that was asked first about what advice there might be for the quick wins. It's consider your environment. You know, is it noisy? Are you in the right place to be having that discussion? Are you giving it in nice chunks, which I suppose comes from patient two? Are you giving people stuff written down so they can refer to it later? Are you really helping people just really break stuff down so that you can help counter those issues with working memory or becoming distracted, you know, being where you might need to repeat? It's, yeah, there's a lot to it. I'd love to be able to say everything. Does that answer your question? Sorry. Okay.
Thank you. Yeah.
Well done, all three of you. It's really great presentations. It's lovely to be at a conference where the patient voice is at the fore, really challenging that dynamic. But it was in relation to the last question, Pauline, and the work that you did a couple of years ago, looking at information provision for people after these shoulder fractures. And what's astounding is that NHS trusts are still publishing information leaflets for patients written by clinicians, physiotherapists, surgeons, for example. And if there's something we could all do differently from Monday, we could start to generate information that's intended for patients, with patients. And that's where your work comes in. But I think not necessarily through formal research, but actually working with your patients. What do you need? And how do you need it? That has to be a next important step. And I think the work that the three of you have done is instrumental in that. So well done. So no question, just a comment. Sorry.
So no, that's a really good point. Sorry, and just quick. So I was in Manchester last year, this time for the Royal Osteoporosis Society for their annual conference, and we were talking about patient involvement in leaflets there. And does anyone have any idea about the average age for literacy in the country? Because it astounded me. Oh yeah, got about 7. So absolutely right. You're writing leaflets. You're thinking about it. You're writing as a clinician. You've been through university. You've got that level 6, 7 experience. Your patient group doesn't have that, and we're using language and stuff that they don't understand. PPIE, so patient participation, absolutely, really, really key. So yeah, really great to include. So yeah, we'll finish it and then we'll come to you in a minute for the end. All right, promise.
It really astounds me, taking it a step further, that every single trust in the country produces separate. It takes so long to produce a leaflet and go through all the governance process and the patient forums, and why we haven't got a national library that we can just use with evidence-based and put our own logos on. I've written to NHS England and asked the question, and I didn't get a response, but it's the time taken for that is just crazy.
So our last question. Thank you.
Hi. Yeah, well done. I thought that was really good, all three of you. I've got an interesting comment, I think, a bit of a mix between Matthew and Pauline's there. But in terms of the ADHD, obviously there's a lot that does go undiagnosed. And the other comment I want to throw in, from a patient perspective, we obviously are looking at tailoring our consultations and adherence. And that's some of the work that I've been getting from my research as well, and how we can make that change, but also thinking of that staff as well. So there's things coming through the interviews I've done, but also in looking at staff and the interaction of what do they remember of the key points that they're delivering to the patient. So you're looking at, yes, the patient needs, but also the staff member and what they're remembering to make their consultation more efficient and, you know, specific to the patient. So I think there's something that we can do to help with the behaviour change of patients and ensure they're listened to more. And then I think looking forwards, looking at some things we can use and implement in with patients in our consultations, whether it is post-fracture or whatever the condition is, something would be useful to implement going forward. So I think sometimes collaboration and using all this information together I think we're all sort of going in a similar direction with this behaviour change from listening to a lot of talks today. So it's, very good.
Right. Thank you very much, everybody. Thank you for that. And thank you to all of you for participating. Thank you to our speakers. I'm sure they'll be more than happy to field questions afterwards as well. Thanks to those online. Please do go grab some lunch. I just want to push as well, if you have time, please do consider coming to the AGM. It's in Exchange 1 at 12:40. If you find out a bit more about what's going on with the CSP and have your voices heard. I'll be around if anyone wants to ask me questions. I hope you enjoy the rest of the conference. Thank you very much. Thank you.